Amir, lovely to welcome you to the Salt Spring Forum for the latest conversation. This time we're going to be exploring COVID-19 and epidemiology, which is obviously one of your expertise, but looking at the range of questions that I've got here in front of me, you're going to be speaking to quite a lot of aspects within the broader subject of epidemiology. But I just wanted to start by talking about the term second wave. We've read and hear warnings about a second wave of COVID-19. And I'm wondering what is meant by second wave, how likely is it to happen, and how should governments respond? Any thoughts?
Why don't I explain why second waves happen?
Indeed.
So when a new virus appears on the scene, and virus of COVID-19 is certainly new, it's related to the SARS virus. Virologists even call it essentially a version 2 of SARS. When it first emerges, nobody has immunity to it. We're all naive to it. We've never seen it. Our immune systems don't know how to react. And when we are infected, then it's illness for many. And hopefully the immune system fights it off, because if not, you might just die. At the end of that, your immune system, though, has experience with the virus. It's learned how to defend against the virus. Immune systems really do learn. So if you're exposed to it again, you're not likely to get ill, or if you do get ill, you will be less severely ill, at least for a period of time that your immune system retains that memory. Why then would we have a second wave? Because when the first wave came, some of us became ill, but the vast majority of us went underground. We locked down, we kept distance from others, and we ensured that we were not infected in the first place. What that means is our immune systems didn't learn. And so if there is a resurgence of the virus in the community, and we go back into the community, we're as vulnerable as we were before. Nothing from a personal perspective has changed. Take that little story, multiply it across the whole population, and that's why, even though we've been through this now for months of being under the threat of a giant explosion from this epidemic, it's thankfully in British Columbia been very well managed compared to anywhere else in Canada. Despite that, you are almost as vulnerable as ever to a second wave. Right.
Okay, because I think we're already looking at potentially the fall. I mean, is that connected to the actual season and flu? Why are we already thinking that fall could be we're identifying the fall as the next time where this second wave could hit us?
Every Canadian knows this. When it gets cold, we come indoors, we huddle a little bit. We become more social indoors than outdoors. More of our hours are spent there. And that means, of course, being closer to one another, sharing things more, and that increases the risk. So will it happen? Will we see the virus come back again well, it's never gone away, but come back to affect more people in the fall than it presently is affecting? Very likely, yes.
Right, a little switch to COVID, to epidemiology and race. In the US, COVID-19 is striking especially hard in the Black and Hispanic communities. Why are Canadian governments not tracking race data for people affected by COVID-19? Should we be? And what are the barriers here? What would we need to do to overcome them? Quite a few questions.
Well, the first thing is just to state the fact. In Canada, we're backwards about how we regard racism. And we do have an attitude of see no evil, therefore it doesn't exist, which is frankly rubbish. Of course it exists. Gouging your eyes out to it doesn't cause it to cease to exist. But we do this quite habitually when, as a society, we do not collect data about race. And we've even manufactured in this completely perverse manner of thinking that to ask about race somehow reflects racism, which is exactly not true, right?
Yeah.
I mean, imagine you were trying to confront sexism without knowing whether a person is a man or a woman. You wouldn't get very far now, would you? Mm-hmm. So we have to have some basic inputs to our knowledge about what race a person is before we can decide whether, as a system, a health system, we're giving care to people who are not white equitably as those who are white. Currently, the federal government and most provinces do not bother to collect any race data for COVID. That is our norm. That is itself systemically racist, because in countries that do collect these data, such as the United States, the United Kingdom, it's very easily seen in the data that people who aren't white have been far more affected by COVID. Their infection rate is sometimes 2, 3, 4-fold higher, the death rate correspondingly. We are sitting in the middle of an epidemic right now in Canada that is certainly disproportionately hitting minority communities, but we choose not to see it.
Right. So the opioid crisis, 170 people died in British Columbia last month from opioid overdoses. That's the highest monthly total ever. And during the same time, 53 people died from COVID-19 in BC. So is the COVID-19 crisis exacerbating the overdose crisis? I mean, are the provincial and federal governments neglecting the opioid crisis while they focus on COVID-19? I mean, what more could be done? What should be done? Why have we got this huge spike in opioid deaths right now?
It's a good question. The opioid crisis and COVID are two separate crises. And we have to remember, COVID has been with us only for a few months. It has not somehow caused the opioid crisis to emerge. That was there much, much earlier. It maybe has exacerbated it because some attention that would have been paid to mitigating the effects of the opioid crisis now has been placed onto COVID instead. But it doesn't really, to my thinking, make sense to view these two evils as somehow in competition. They're both evils. I think the only solution that there is for the opioid crisis is what Dr. Bonnie Henry has said. I agree with her fully that you have to decriminalize possession of personal quantities of drugs. Take the problem out of the criminal justice system and place it more firmly in the public health system. I'm a public health guy who's also a lawyer. And to my thinking, it's not even close. This is much more of a public health problem than a legal problem. And not just questions of health as far as addiction goes, but the underlying predisposing conditions to addiction, often psychological, sometimes born out of trauma, certainly having socioeconomic determinants as well. Yes, there are very wealthy people addicted on opioids. They, however, manage the consequences of their addiction generally better than those who are much poorer with fewer social supports. This is fundamentally a medical condition that is psychological and has social determinants. And you're not going to address that through the criminal justice system, ever.
Yeah, thank you. So developing world, we're sort of jumping around it a bit, there's so much to cover. So COVID-19 is now spreading through the developing world with devastating effects, such in countries such as Brazil and India. And our youngest son has been studying in India this past year and is really looking forward to going back. But
where is he now?
He's here now, but he was studying at Mahindra College in India. But so he's looking forward to going back, but really uncertain at this moment whether that's going to be at all possible. So is it possible to stop or even manage the virus in countries with widespread poverty and poor healthcare systems? I mean, is there anything here in Canada that we can do to help?
It's not just a question, I think, of developing countries being hard hit. It is a question of badly run authoritarian countries being hard hit. If you look at the countries that are topping it for cases or deaths, they are Donald Trump's United States, Jair Bolsonaro's Brazil,
Yeah.
right?
Yeah.
Modi's India.
Mm-hmm.
And this is not accidental.
Mm-hmm.
It is something about populist governance has led to decisions different in each country that has allowed the virus not to be interdicted in a timely way, and the virus takes advantage of it. And viruses are amoral agents. They're not immoral, they're amoral. They have no morality whatsoever. And so when they confront a country or political system that possesses a strong ideology and quote-unquote morality, if I can apply that term to Donald Trump, that what happens is that the virus proceeds oblivious to any of that. It has no ideology or morality, but the ideology and morality of those people who are seeking to fight it impedes them doing so. And so we're seeing this in rich countries, in poor countries. Being poor, being a developing country is not itself a guarantee of failure here. Ethiopia has done a far better job at testing and screening people door to door in the national capital than Quebec has done in Montreal. There are some success stories among poor countries. I think the more dangerous thing than being poor is being ideologically populist, denying science, denying that this virus can get its hold into your people, indulging nonsense like using chloroquine or thinking that injecting disinfectant will help you. That sort of magical thinking is worse than the virus itself.
Yeah, absolutely. Right. Well, we have a lot of questions still to get through, and some of these have been sent in through the Tyee and the Salt Spring Forum. And I do have one here from Jason from Bowen Island. And the question is, we know that the elderly and people with underlying health conditions are at greatest risk, but we are learning that COVID-19 is causing sudden strokes in young adults and toxic shock syndrome in children, with symptoms including stomach and heart problems. Are there other viruses that infect different blood groups, ethnicities, and age groups differently? Have we seen this elsewhere?
I mean, the easiest illustration of that is influenza, right? Influenza, we've all had the flu. I don't think there's a single person watching this who hasn't at some point had the flu. It does kill the elderly more often than it does the young, just because of the general fact that the older you get, the less responsive your immune system is, and the less, if I can put it in those terms, less reserve capacity that most of your physiology has for any sort of insult that a virus or pathogen may bring. Some other viruses, though, not especially prevalent among the elderly. Think of HIV and AIDS. That is, of course, going to be found in people who are maximally sexually active. And so it affects adults in their younger years. Anytime you think of a virus, a pathogen, and a human, think that you are not dealing with something rigidly formulaic of one organism versus another. No, don't think of it like that. Think of it as though you're immersed in an ecology, because that's really what it is. Viral pathogenesis, the spread of disease, what we call epidemiology, the way that it manifests itself, the pathophysiology in medicine, all of this has essentially an ecological feature to it. It's a function of the host, it's a function of the virus, and it's a function of the environment in which place the interactions occur.
Right. And a little bit, sort of connect a little bit, and also I'm rather curious on this question from Don Smith, or the answer to this question from Don Smith of Toronto. How significant a factor is asymptomatic transmission? And how does this relate to the issue of children and youth and the reopening of schools? I've been back in my classroom for 2 weeks now with a small group of children, part-time. And obviously the social distancing, so we're being incredibly careful and following the rules. But what's the data? What are we looking at with asymptomatic carrying and transmission of this virus?
That is such a great question, and it's such an important question, and it's one that I'm a father. I have to reckon with it for the sake of my own children, and I will say that I don't know what my answer is yet. Whether I'm going to send my kids back to school in September or not. Here in Ontario, we're not as fortunate as British Columbia. Our province is failing. We have still quite a large number of cases, several hundred a day. And so it's a question of whether we will be able to send our kids to school safely. But I'll tell you what I'm watching and the things that will go into my decision sometime this summer. I want to know better how often it is that children who are infected acquire severe illness. So far, that seems rather low. I want to know what we call in science the secondary attack rate. That is to say, how often is it that an infected child passes the infection to an adult? There is a scintilla, a whiff of evidence that infected children are actually very inefficient transmitters to adults. I definitely hope that bears out in the next few months of more careful study. But right now, it looks like children are not especially good at passing on infection when they have it, which would mean that the school environment would be safer, both for other children, for the teachers, and for the parents at home. I'll also be looking to what might be, if we're lucky, some advances made in treatment between now and September. A vaccine isn't coming as quickly as that. I think a vaccine will come sometime, at least be proved to work sometime by the end of the year and commercialized next year. But before then, we may have treatments that lessen the severity of disease, so that if one gets disease, at least it isn't a death sentence. All of these factors will play into my decision when sometime mid-August I put myself in a hammock, open a beer, and think about the well-being of my children, and I decide what to do with them.
Right. And that enough time will have passed. There'll be enough data at that point for you to make that informed, sort of educated decision.
There'll be more than there is now.
Well, right.
All I can say to parents, and I say this to my own wife, all I can say is thoughtful temporization. Temporize. Don't take the decision now about school in September if you can, but be thoughtful between now and then, both about what your personal risk comfort zone is, and what your ethics are. Would you want to send your child to school if it presented a threat to other people? And at what point would you accept that the threat is so minimal that it doesn't engage a difficult moral question? In the meantime, the science will evolve. It'll improve a lot, and we'll be able to have this conversation later and maybe have some greater clarity on it.
Excellent. So Jerry Bloomer, New Westminster here in BC, considering the long-term health consequences. So are recovered cases of COVID-19 fully 100% recoveries? Or could there be chronic long-term side effects and compromised health issues? How should the answer to this question affect public health decision-making? Can we just manage the disease, or do we need to shut it down completely?
There's no doubt that COVID, like other respiratory infections, once you are quote unquote healed, meaning that you have no virus left, you can still be left the worse off. Your lungs could have been damaged. Other organs could have been damaged. That's entirely possible, but that's not in any way unique to COVID. The same can be true of influenza. The same is true of tuberculosis. Other respiratory infections are like this too. If you come out of COVID with lungs like shoe leather, then yes, you're going to have some chronic illness and rather serious chronic illness to deal with. That maybe gives some people incentive to be more careful who right now aren't being careful. I hope it does. This is not as simple of a question as, do you live or do you die? No, you can come out of it with illness that dogs you for the rest of your life. As to whether that makes a difference in how we fight it, no, not really. I mean, the goal here is to try and ensure that as few people are infected as possible between now and the time when we have a vaccine that can protect us better from it. It will never go away. And let me be very clear about this. SARS-CoV-2, the virus that causes COVID-19 disease, will never go away. It is endemic. It will be here 50 years from now.
Yeah.
It has emerged. It's found an ecological niche in us. And it probably will go on infecting people again and again and again. We don't know how long immunity lasts. It could infect the same person more than once, maybe a number of years later. These are questions we don't totally understand as yet. But the existence of this with humanity, we're married to it now. And the best we can do is manage it, and vaccination is really going to be our best strategy for that.
Right. Regional differences. Now, there you are sitting in Ottawa, Ontario. Here I'm on Salt Spring Island, British Columbia. So Greg Spingen here on Salt Spring Island notes that especially Ontario and Quebec have had a much higher caseload of COVID-19 than similar countries like Australia. Why is that?
Oh, look, Canada's failed for the most part. I know this must be hard to understand from a British Columbia perspective because you're the one province that's done brilliantly well. But if we don't look at provincial boundaries, we just look at Canada. Canada has done a dismal job on COVID-19. Shocking. I never thought I would be in a country that did as poorly as it's just done. And to put it in context with just one statistic, if I could please. Today, we've had roughly 8,000 deaths of COVID in Canada. Australia has had barely 100. 80-fold difference.
Yeah.
Now, they're similar countries. They're both federal, right?
Yeah.
The central government, and then in Australia, the states, or here the provinces. They're both very large. Australia is a continent unto itself. We're not small either. They're both sparsely populated.
Yeah.
We ought to be in a fairly similar situation. And no, it doesn't really matter that Australia is an island and we're neighboring the United States. That doesn't matter because when we closed the border with the United States almost totally, that was mid-March.
Yeah.
And in mid-March, we had roughly the same prevalence of COVID-19 in the population that Australia did. We were tied with Australia in March.
Right.
The reason that we've gone separate ways since has nothing to do with our border. That has been almost totally closed. It has to do with the way our governments have responded. In Australia, the federal government had a national plan to deal with COVID in February. They worked with the states to get a buy-in from all the states of this plan. On March 13th, they signed an agreement, all the state and federal government leaders together, that they would implement this plan, and they agreed how it would be paid for, and they did it, and they succeeded wildly. Their response is one of the best in the world. Without the heavy-handed human rights violating responses we've seen in some Asian countries. Australia culturally is quite like ourselves. We could have been them. Why weren't we? Because the federal government in Canada under Justin Trudeau took a weak hand and did not try to have a national plan. Here in the middle of June, there still is no federal national plan for COVID. They did not come to an agreement with the provinces of how responsibilities would be shared to achieve this non-existent plan. They never attempted that.
Right.
And so every province has been left to its own devices, left to reinvent the wheel. Guidance from the federal government has been absolutely appalling, to the point where sometimes it's been scientifically incorrect. And here we are, with certain provinces having succeeded. British Columbia, bravo. The Maritimes, bravo. And Quebec an abject failure. If Quebec were sovereign, it would have one of the highest death rates of any country in the world.
Right.
That is, if I can just add it, that is the clearest possible proof that Canadian Federation is a failure as we now perceive it.
Right.
Because the highest duty of a nation, of a country, is to save the lives of its citizens. If it can't save the lives of its citizens, it is failing in its most fundamental ethical obligation. And that's what Canada has just done.
Right. So moving on to testing. David Cassidy here on Salt Spring Island. British Columbia has done less testing per capita than most provinces, yet, as we know, our outcomes are better than most, as you've just illustrated. We accomplished this by focusing testing in potentially high prevalence settings and quick contact tracing. What are your views on population-based testing to determine the prevalence of SARS-CoV-2 exposure?
Well, that's a different kind of testing.
Right.
There's testing for the virus, which will tell you if a person is carrying the virus and therefore could be made ill of it, and more importantly, could pass the virus on to someone else. But then there's a different kind of testing, not virological, as I've just described, instead immunological, testing for the antibodies that are present in a person's blood after exposure to the virus. Now, that's a completely different kind of test. And what one could do is test a large number of people in BC's population or any other population and ask how many of them bear those antibody hallmarks of past infection, and therefore how many of them stand a chance at some, or with luck, total immunity to future infection. That has not been done widely. These are called serosurveys, and they have only been done in a few settings. Where they have been done, they show that we are nowhere close to the majority of the population having been infected. We're in most settings, single-digit percentages of people who have been infected. And I'm certain that would be the case in British Columbia if you did the study. Right.
Okay. Now we're sort of moving on to national reporting standards. Randall Wolford has the question, how can we put any confidence in the federally released data on COVID-19 when it seems each province has different ways of measuring and reporting, and what legislative tools are available to implement common data standards and measuring tools across the provinces and territories?
Before we get into that, let's just talk about the problem, okay?
Yeah.
Garbage in, garbage out. If you put garbage information into your public health system, then when your public health system has to devise and implement an epidemic response, it too will be garbage. This country is the master of garbage in, garbage out for epidemiological data. As we speak today, the federal government, the Public Health Agency of Canada, possesses under 50% of the data on cases of COVID known to have occurred in Canada. Over half the cases that have occurred have not been fully reported to the federal government. That is how bad our data sharing is. That we are missing in a national database over half the cases that have occurred. Why? Because we're primitive. The majority of public health units in Canada communicate by fax machine in the year 2020. That's right, fax machine. They do not email information about patients because they have a belief, false of course, that email is not secure, but the fax machine is secure. Now that's obviously nonsense. You know, other people who have to keep information secure, like your bank or like Canada's spies, do not use fax machines. They use electronic communications. But the health field has maintained this fiction that only fax is secure, and therefore they're only willing to channel information about disease outbreaks through fax. Now that leads to enormous delays in having to type the data in again, Montreal, just the city of Montreal has hired 24 typists since COVID began to type in faxed information, if you can believe that. And it also, aside from the delay, aside from the cumbersomeness of it, it means that we are not able to, in real time, make scientifically meaningful statements or forecasts about where the disease is going. Because we're waiting for the fax machine to spit out another page and for someone to type it in. And because of that, we have half the data on the cases that have occurred. This is our single greatest failure at the operational level in public health right now. We have not evolved past the fax machine in 2020. And just to put in context how backwards that is, I used to work with colleagues in Southern Africa on a malaria project around the year 2000, 2001. We notified cases in rural Africa 20 years ago by email.
Right.
And in Canada's most powerful cities in 2020, it's by fax.
Right. So are there legislative tools available to implement these common data standards? And measuring tools across the provinces and territories? Just as I go back to the question. No, thanks for the background. Absolutely.
So there are ways this could be solved. After the SARS outbreak, Parliament passed a law that created the Public Health Agency of Canada, and it gave Cabinet the power to compel provinces to hand over epidemic information.
Right.
To this day, the Trudeau Cabinet has not used that power.
Right.
They're refusing to use it. And this goes to my critique of the Trudeau government being as phenomenally incompetent on COVID as you could imagine. Even Rwanda's government has an up-to-date central database of cases. Rwanda. And Canada does not. And the fault for that lies in not just the antiquated mechanisms of the fax machine, but the fact that we have a federal government unwilling to use the powers Parliament has given it to compel the provinces to report better data. So it's a political failure.
Right. So moving to sources of data that public access. So Anne Parkinson here on Salt Spring Island has the question, many members of the public have spent a lot of time educating themselves about COVID-19 and epidemiology in the last 3 months. There are lots of websites offering data concerning the pandemic. Some of these are obviously dodgy. Some of them, such as Worldometer, seem quite good in our opinion. Where do you get your data? Where can members of the public find reliable data?
If you're talking about case numbers or deaths or trends in how the epidemic is growing or shrinking in different countries, the best raw source of data is the European Centers for Disease Prevention and Control.
Right.
It is difficult to get through their website and find what you want. So there is another website called Our World in Data. It's run by Oxford University. And it makes use of the European CDC data, but tends to produce prettier, flashier, easier to navigate graphs and that sort of thing. So if you're just looking to see how the disease is moving in different parts of the world, that is a good place to begin. If you're looking for information about the epidemiology produced by scientists, or the immunology, or the virology, or the clinical medicine, well, then you really do need some specialized skills, because those bodies of literature are not easy for people without the training to understand. And even though I have a PhD in this kind of thing, if I step just this much outside of my field, oftentimes I don't understand the scientific literature. That is a tough space for a layperson to get a hold on. Yeah,
fair enough. No, thanks. There's some good recommendations there. So politicians versus experts. Kari Taylor, Victoria, here in Victoria, British Columbia, Was one of the critical failings in Ontario and Quebec that politicians hogged the microphone rather than ceding their time to experts? You think of, yes, obviously politicians in Quebec and Ontario, compared to, we were hearing from the experts here in BC. Bonnie Henry is the forefront of our the control and the advice that we're getting from through the government. How does that compare to Ontario and Quebec?
Look, it's an excellent question. And to answer it, I think you need to go a little bit deeper. Mm-hmm. It is true. Some places seem to put their politicians front and center. You know, Doug Ford often gives presentations on COVID for Ontario. François Legault does so for Quebec. Federally, at 11:15 Eastern Time every morning, Justin Trudeau comes out from behind the closed doors of his cottage, walks to a podium, and speaks. It's almost like a cuckoo clock. You could set your watch to it, that the doors open and out he comes at that designated hour. I think this is foolish because a government that chooses to present itself that way is, perhaps without meaning to, tipping its hand that it is approaching the pandemic as fundamentally a political problem rather than a scientific one. Mm-hmm. It is better to approach it as a scientific one for obvious reasons. And while you are doing that, you are likely to come to the conclusion that you should really let the scientists speak, as in BC, where Dr. Henry has been so prominent. The only exception is where you've got a politician who is very competent in science. In Germany, the Chancellor, Merkel, has been forward talking about COVID because the woman has a PhD in chemistry. She's scientifically very smart herself. That is not Justin Trudeau. That is not Doug Ford. It's not François Legault. And so in these other settings, we have unskilled, unqualified people applying the wrong frame of reference, a political one, to what is fundamentally a scientific problem. It's as if a hurricane were coming, and instead of the weatherman or weatherwoman explaining it, Justin Trudeau stood up to explain the hurricane. That's how silly this is.
Right. Yeah. Question about homemade masks. Diane Varga of Nanaimo. Do homemade masks actually work? Or are we being told to wear them so that we feel we're protected and protecting against COVID-19 so that we all get the economy running again? What's your thoughts on that?
Well, it all comes down to the quality of your homemade mask, doesn't it? And if I were the one having to make them for this home, I suppose we may as well phone the Grim Reaper right now because I couldn't do it very well. But if you're skilled at it, if you follow directions better than me, yes, you can make an outstanding homemade mask. And the latest scientific evidence suggests you can make a homemade mask that rivals the performance of even those vaunted N95 respirators we keep hearing about, the breathing masks that are used for the most critical medical procedures. A top quality homemade mask can approach that level of efficacy at blocking small droplets, the ones that cause infection. And if you're looking for some guidance on this, I'll just give you a few points. Number one, make sure the mask fits, because it doesn't matter what material it is. If it doesn't fit, if it doesn't cover your nose, cover your mouth, don't wear the mask down here on your upper lip. That won't protect you. It's got to fit first. Second, masks made with different materials, different layers of materials, outperform those made with one material. And in a recent biophysics study that I saw, the combination of 600 thread count cotton plus a second layer of either silk or chiffon, when it fit, a mask of that sort was comparably good at blocking droplets as an N95 respirator. If you have a mask like that, If you're able to make one, maybe I should give my home address. Please mail me a few. But that is the sort of thing that you need, and it will definitely protect you.
Good. Right. So for masks, the vaccine safety. Aziz Maimon of Calgary. Are COVID-19 vaccines being developed using the same historically based or established methodologies as other vaccines? Do Canadians have to be worried about their rights with respect to mandatory vaccinations? Where are we at with that?
I'm going to say upfront. Yeah, I'm going to say upfront. I am an enormous vaccine supporter, and I have no time whatsoever for people who confect exaggerated stories about the risk of vaccination. Are there risks to vaccination? Of course there are. That's not the question. The question is, do the risks outweigh the benefits or vice versa? And for every vaccine that has ever been produced for humans, the benefits outweigh the risks.
Yeah.
And I expect it to be so for any COVID vaccine that emerges. There are 3 of them that are at a stage of development right now that I can say personally, I feel highly confident they'll result in successful vaccines for humans. When 1, 2, 3, or maybe even more vaccines are available on the market, do I think that their use should be mandatory? Yes.
Right.
I believe they should. Because this is a disease where if one is not protected, one risks to spread it to others, and the consequences for others can be greater than they are for oneself. We live in a society where we even have rules on having to mow your front lawn. It's mandatory to mow your front lawn so as not to be a blight for your neighbors in many places. I fail to understand why we have a social tolerance for mandatory rules on lawn mowing, and yet when it comes to life-saving interventions, an enormous civil liberties battle ensues. I believe in civil liberties. I've gone to court to defend civil liberties. I have worked in that field quite a lot.
Yeah.
But for vaccines, my God, we must use them. Thank
you. And last question, actually, and we're going to think beyond now, beyond where we're at today with the pandemic sort of still with its stronghold around the world. It's from Rob James on Salt Spring. It seems certain that there will be inquiries at the national level and in Ontario and Quebec when this all settles. Aside from the usual assess preparedness, learn lessons, mandates of such inquiries, what novel things should be in the mandates, and do they need to have powers of subpoena?
All inquiries typically have powers of subpoena, so I think that will be there. You're right. I mean, the inquiries are inevitable, and there will be several of them. My bigger concern is what happens to the findings, because remember, after SARS, this country did all manner of soul searching. Research was done, studies were done, a judicial inquiry occurred. And how many of the recommendations from those exercises were adopted into reality for COVID-19? Virtually zero, which is why we're still using fax machines in 2020 to get epidemic information to the place it's needed, much too late, much too ineffectively. Our federal and provincial governments have no record of positive collaboration on health, just like they had no record of positive collaboration on climate change. And what finally moved things a little on climate change was the Liberal government's understanding they needed a carbon tax, and they needed it largely to uphold Canada's international commitments on climate change. It was having the international commitments became key to finding the political resolve federally to bring in a carbon price. I don't believe for a moment Canada is capable of solving its own problems of epidemic response and control. It's failed with SARS. It didn't do a good job with listeriosis. It's done an awful job with H1N1 influenza. And it's failed to an extent on COVID-19 that even low-income African countries in many instances exceed its performance. if it's going to change, it's going to change because there is international law, treaties, something from the outside that forces Canada to move to a higher standard. And then we will drag our maple-drenched knuckles across the floor to do what's necessary to come into line with those international standards. I have lost all confidence in our domestic ability to motivate change in this area. It will have to come from an international impetus.
Right. Thank you. Thank you, Amir. Thank you so much for being with us here today and for answering all those questions. You really covered a lot of ground. Yeah.
Thank you so much. I wish I was in Salt Spring and able to share a day with you, but that will come.
Absolutely, it'll come. Open invitation. We really look forward to seeing you here one day.